onto the dais, please. I request Dr. Vishnu Abhishek sir to start off with the case presentation.
Good afternoon. Thank you for the moderators and panelists, and thank you for the organizing team for the opportunity. This is just a real life case we just discharged, so we'll just go through. It's a common case. 71-year-old gentleman. Next slide. Can we go to the case, please? Yeah. Yeah, that's all. So the history is 71-year-old gentleman. He presented on Jan 23rd with acute abdominal pain in Bangalore, one of the private hospitals. Initial amylase was raised, counts were mildly high, and PCV was 49. Rest of the labs were normal. He was hospitalized for acute pancreatitis, treated conservatively with moderate aggressive fluid resuscitation, and on third day he developed breathlessness. Contrast CT showed interstitial necrosis of the pancreas with 20% necrosis, and there was pleural effusion on the left side. He was managed in ICU with oxygen support, and after ICU he was discharged 3 days later. So on 7th day he was discharged, but the next day he presented again with fever and exacerbation of pain abdomen. So 7 days of hospitalization. On 8th day he presents with fever and hospitalized. So I think there are some questions based on this presentation, and the answers probably will be answered by Dr. Sudipta. Does fever always mean infection? How to differentiate the fever of infection from SIRS? What will be the next step if it's an infection? Is there a guideline for antibiotic usage in pancreatitis?
Thank you, Vishnu, and thank you TNISG and Dr. Venkatakrishnan and Mukundan for having me here. So Vishnu has some very pertinent questions as regards acute pancreatitis is concerned. And that's a common scenario. Patient comes in within the first week of illness. Patient has high-grade fever. Are we dealing with SIRS? Are you dealing with infection? How do you discriminate both of them? So we all know that acute pancreatitis is probably one of the most common GI emergencies that we encounter after GI bleed. And if you go to a general gastro ward, more often than not, most of the patients are actually having acute pancreatitis or cholangitis. That's the most predominant cause of admissions to many hospitals. If you look at the estimated incidences, 110 to 140 per 100,000 population, and this disease is characterized by a significant inflammatory reaction. Now, why I put up this slide is to understand what is actually happening. So whatever be the etiology of acute pancreatitis, what happens is the acina cells get damaged with the release of calcium within the cells, leading to a programmed cell death. When this programmed cell death, the cell particles, which are now disease-associated molecular patterns, are recognized by this antigen-presenting cells, and as a result of which there is attraction of neutrophils, macrophages, lymphocytes, and of course the endothelium gets damaged. And there is a pro-inflammatory cytokine response with TNF-alpha, interleukin-6, interleukin-1 beta, and all of this produce systemic inflammatory response syndrome leading to multi-organ dysfunction. Now this heightened inflammatory response is variable, whether we are dealing with a mild or a severe acute pancreatitis. In mild, you have less degree of severe inflammatory reaction. When you compare to those of severity, higher severity, then there's the inflammatory reactions are much higher. And early phase, there is SIRS. As the patient recovers within the first week, this significant inflammatory response is taken over by another form of inflammatory response called the compensated anti-inflammatory response syndrome. And this is a transition zone. What happens is that when you have a heightened amount of pro-inflammatory cytokines coming out, followed by you have an equal amount of anti-inflammatory cytokines response, and that is at the period of which the patient is actually immunodeficient, leading to increased risk of infections. And where's the source of infection? Most of the infections come from the gut. Pancreatic necrosis or inflammatory response increases gut epithelial dysfunction, translocation of bacteria, predominantly Bacteroides, Proteobacteria, and that leads to a systemic bacteremia. So you have dead tissue, you have bacteremia, and immunocompromised state. All of this is a good culture media for infections to start. So we, in our center, we looked at the type of infections that happen in acute pancreatitis, and this paper came out very recently in DDS. So what we have is, in the first week, when the patient comes in with fever, most of the fever is because of an inflammatory response. Of course, there is infection, but infections are predominantly extra pancreatic in the form of cholangitis, lower respiratory tract infections, bacterium of undefined sources. By second week, this predominantly becomes infected necrosis. And beyond the second week, it's mostly infected necrosis. So the key here is, how do you discriminate these two? Inflammation versus infection. And if you look at the source of infection in acute pancreatitis, this is from the same paper, the predominant source of infection was in overall, I'm talking about the entire cohort of 150 patients. Overall, it was predominantly infected necrosis, lower respiratory tract infections, bacteremia, cholangitis. We did have some 7 patients with COVID-19 and acute cholecystitis. If you look at the profile of bacteria that we get in patients with acute pancreatitis, you have a host of bugs. Most importantly, what we have to realize, there's a high prevalence of drug resistance organisms in acute pancreatitis. And in this study, we show that 66.7% of the infections was caused by multi-drug resistant organisms. 94 GNB isolates were identified. 5 were ESBL producers, 25 were CROs. If you look at the GPC isolates, 3 were vancomycin-resistant enterococcus, 2 were MRSA. We also see fungal infections, acute pancreatitis, but what we see also is that that is predominantly associated with prolonged ICU stay and antibiotic usage. If you look at where the source and what bugs we get from different sources, if you look at a respiratory source, it's predominantly Acinetobacter baumannii. And if you look at the pancreatic and the blood, it's most often the gram-negative bacilli. So what is the role of antibiotics then? This is an international multi-center study, involved 9,869 patients from 23 countries. Now what they showed was, this was a study looking at global overuse of antibiotics and based on the evidence that is there. So this was run primarily by the Hungarian pancreatitis study group. And what they showed was the highest rate of antibiotic usage was in Asia, primarily China and Taiwan. We didn't have India in that cohort. I think it would have been the same numbers. Eastern Europe, Albania, Bulgaria, very high. 70 to 80% of patients with acute pancreatitis receive antibiotics. However, vis-a-vis when you compare to the Westerners, in Spain and United Kingdom, the use of antibiotics is only around 30%. So the truth lies somewhere in between these two numbers, that probably there is a need for antibiotics, especially in our center and our centers, but we have to be judicious where we use it. More importantly, antibiotic therapy was not associated with decreased mortality or severity. So very early in illness, so especially in the first week or early second week, it's very difficult to differentiate fever, which is of inflammatory origin, from that which is of infection. And patients with acute pancreatitis, we know that are at risk for infections that we just showed you, and infections in acute pancreatitis severely affect the outcome. And most infections that happen early on are of extrapancreatic origin. Now what happens if a patient has fever in the first week? If you look at this cohort of patients, this is from our study itself. If you look at the outcomes of those patients who had fever in the first week, most of them, 17% has serious adverse outcome, that was mortality or leaving the hospital in a critical state. Organ failures were there almost to the tune of 50%, ICU admissions 30%. If you look at the sources of infection, again, that we told was cholangitis, infected necrosis in a very small percentage. This was again suspected, lower respiratory tract infections, bacteremia. So how do you discriminate? Now, there's been a lot of talk about different modalities to discriminate. One of the discriminants that have been used has been procalcitonin. Procalcitonin, as you all know, is a prohormone of calcitonin secreted by the C cells of the thyroid in normal conditions. Now, in the presence of endotoxins, cytokines, especially IL-6 and TNF-alpha, there's a profound release of this procalcitonin, and that is from the liver, pancreas, kidney, intestine, and the leukocytes. And this has been shown to be a promising biomarker in systemic infections, especially when you're dealing with sepsis. So then there was the single center randomized trial from UK. So this single center study looked at use of procalcitonin guided antibiotic use in acute pancreatitis, or which is called the PROCAP study. 260 patients acute pancreatitis were randomized 1:1 with a procalcitonin guided care versus usual care. The intervention was procalcitonin measured on 0, 4, 7 and weekly thereafter. And if the procalcitonin was less than 1, avoid or stop antibiotics. If the procalcitonin is more than 1, start or continue antibiotics. The primary outcome was antibiotic use during hospitalization, and they showed that procalcitonin guided care significantly reduces antibiotic use without increasing infections or adverse outcomes. Now the problem with the study was 95% of the patients were mild acute pancreatitis. So it really doesn't represent the truth that we're dealing with in our day-to-day practice. So we started looking at another aspect of it called the neutrophil lymphocyte ratio. And LLR basically characterizes a balance between innate and adaptive immunity. Innate neutrophils are a part of innate immunity, adaptive in lymphocytes. And when there is infection, we think there is early response should be with the form of innate immunity. So NLR has been used reliably in sepsis. Higher values in sepsis indicate poor prognosis and correlates with the degree of sepsis, especially SOFA scores. And NLR and interleukin-6 appear to be independent predictors of a 28-day mortality in septic patients. So it has been used in sepsis, and we looked at it in acute pancreatitis. And when we looked at it, interestingly, when we compare to procalcitonin, NLR seems to have a better area under the curve as compared to procalcitonin. So probably this is a very simple score. All you need is a neutrophil and lymphocyte at the time of the first culture that you take when the patient has fever. And if it is more than 9, high risk of patient having an infective problem. So just to summarize what Vishnu asked me, what are the societal guidelines? Currently the societal guidelines, and this is a summary table, there is no routine use of prophylactic antibiotics, and societal guidelines say that you should do antibiotics only when there is positive microbial cultures or gas in the bubbles. Gas bubbles in the collections. But there again, there is a substantial proportion of patients who do not have these, and still we suspect infections. So most of the guidelines put it in the text that if you have a high suspicion of infection in the form of either organ recruitment, multi-organ failure, high-grade fever, then you may consider antibiotics. So to summarize, infections are common in acute pancreatitis. Key is identifying the patients having infections and treat the source of infection. When it's cholangitis, do an ERCP and biliary drainage. If it's a lower respiratory tract infection, treat antibiotics. It's a WON, drain the system. Thank you, and I welcome all of you to the annual meeting of the Indian Pancreas Club, Pancreas 2025, which is going to be this time at Vellore on the 4th and 6th of September 2025. We'll hear more about pancreas there. Thank you so much for your patient hearing.
Can you ask questions now? As no, you can sit here also. See, now you have told that only 2 indications for giving antibiotics. One is, no. Suppose the patient has got a high procalcitonin. The patient was admitted, procalcitonin was less than 1. Because in my unit, we follow procalcitonin as a criteria for starting antibiotic. And I just want to know that suppose on the 7th day, this man has a procalcitonin of 4 or 5, what will be your approach? Structure is negative.
Exactly, sir. So procalcitonin should not be interpreted in isolation. Neither NLR nor procalcitonin can be interpreted in isolation. So an absolute number holds no value without a clinical context. So if the patient has got organ failure, high spiking fever, your procal is high, your NLR is high, then more likely you're dealing with an infection. But an isolated procalcitonin, I probably would not give that much credence. It's just like CRP to me.
Sudipto, I thought you were speaking on the first week. So usually the first week or 10 days, infection of necrotic collections, etc., usually don't happen because they come from the gut. What I've often found is they're usually extra pancreatic infections, cholangitis or lung infections or something else where we miss out, or even urinary tract infections. This is my experience in this.
Absolutely right, sir.
Sir, you're absolutely right. Actually, what we have in the data we have shown also, only the 6 who were admitted to the ICU with high spiking fevers and organ recruitment was suspected to have infected necrosis because there was necrosis on the CT scan imaging and they were started on antibiotics. But these were suspected, only 6 of them out of a total of 98 who had fever within the first 1 week. Most of the infections that we have been extrapancreatic, as you said correctly, so bile, lower respiratory tract infections. In fact, we are seeing a lot of lower respiratory tract infections that could also be co-founder, because sometimes when you do the sputum culture, you usually see Acinetobacter baumannii. I'm not sure how much of it is actually true, but we have to go by the cultures. So we do see a lot of Acinetobacter baumannii in the sputum cultures, urinary tract infections and lung infection. These are the things. So, infected necrosis is hardly there. Whatever we have is highly suspicious of infected necrosis, but we do not have any definitive evidence of infected necrosis.
So having said that, infection in the first week, 80% they resolve, but in case if they develop an infection, does it, fever or high leukocytosis, does it automatically speak for infection, or it is a cytokine storm? Because what they say is an organ failure happening in the first week, the outcome, compared to organ failure happening after the second or third week. Because here it is a cytokine storm, which is very, very difficult to treat, and hence the mortality is very high. Whereas the organ failure happens after the second or third week, which is more of infective necrosis, where we have some control, either endoscopic or percutaneous or drainage. So first week infection is a red flag, possibly.
So first week infections
may not be infection.
Yeah, first week infections are usually
one more point. In this case also, no, he had hypoxemia, old age, he had some breathing difficulty.
He went to
so
ICU and then he came
It doesn't
out.
speak for infection. It speaks that it could be
He was
cytokine storm with
discharged and then he came
ARDS
back. He came
or
back on
something
day
like
8.
that.
Second week he came back with fever.
Yeah, he came with fever. So there are all features which says that though he got discharged, but this fellow is going to have not a straightforward course.
But it also could be a hospital-acquired infection. He came out of an ICU, sir. He came out of an ICU. So that's also a problem that we have to understand, that when they go to the ICU, there's a high risk of getting infections, cross-transmission between patients. So
the presentation itself is fever, leukocytosis, is tachypnea.
So
that need not be.
Just to spice up the discussion, maybe the second line, Procal and CRP are raised on day 8. And one thing I specifically didn't mention in the slide 1 is this is a gallstone pancreatitis. So when he presents with an altered LFT and raised procalcitonin and CRP raised day 8 of pancreatitis, after sending out cultures, X-rays, CTs and urine culture also, whatever it is, do you want to err on the side of starting the antibiotics or wait for the cultures to start the antibiotics? So panelists. Would you start right away after the cultures, or would you wait for the cultures to come back, since you think it's SARS and not infection? We have all been there, like whether to start antibiotics or not. That is a gray zone scenario. It's day 9. It's not exactly the end of SARS. It's just starting.
Yeah, the patient is persistently unwell with the collection. Suppose, so you are asking on the day 7.
It's day 8.
Day 8, and I think I will embark on an antibiotic. Because it's very difficult to differentiate, and we are not going for any puncture to prove it, because I don't think any centers does that. Because we rather will add more infection.
So I think we can safely agree almost all of us would have started antibiotics.
If the patient is clinically deteriorating, there is all the more possibility that will definitely start. Sure. I just want to ask a question to you. This patient, the way you presented, it appeared to me that is a very mild pancreatitis. You told it is an interstitial pancreatitis. Patient was discharged on 3rd day, and now
patient was admitted in ICU on the 3rd day.
I want to ask one.
Transferred out to ICU.
Matthew, I want to ask one question. Patient presenting with pancreatitis on day 1, day 2, who has breathing difficulty and pleural effusion. I think there's a straightforward clinical parameter to say that this is going to be severe acute. Particularly patient with pleural effusion, because he might as well have a lung infiltrate. It could be an early ARDS
even
also.
I thought so. This is probably
and
by
old
more than
age,
2. It's not in my center. This is outside. Yeah,
no, just for discussion.
It is not mild acute pancreatitis. This is not mild.
So we can go by the CT showing interstitial pancreatitis, because CT done within 72 hours probably will not reflect the degree of necrosis that we are dealing with. So probably that would have been an undercalling here, but the clinical scenario was of a severe pancreatitis. Yes. He had organ failure persisting for more than 48 hours.
So CT's ability to predict a necrosis on upcoming necrosis, that's a different topic of discussion. Pramod Garg says favorite topic. He will differ from your opinion of view because he prefers a CT with contrast actually predicting an oncoming necrosis, isn't it? Yeah, but there are gray zones for that.
That's a different story.
Different story, yeah.
We are talking there of endothelium dysfunction and hypercoagulability, but that's a different story.
So, but there is one more thing, like CT done with two phases.
Mike, sir, Mike?
That's what called a CT perfusion scan. What is that CT perfusion scan, no? It's something coming up.
Yes. Sir, actually, many centers, they don't do the two-phase CT. We ideally should do the CT at two phases, 40 seconds after giving contrast and 70 seconds. So that is the one which picks up the necrosis best. So the 40-second pancreatic phase, that is the one which picks up the necrosis best. And as sir told, perfusion is also one good.
No, but perfusion scan, the literature says, but why we are not following it routinely? No, it's a simple. I mean, I'm just my doubt.
Yes.
Because it says that who are the patients who are going to go in for necrosis. But why it's not followed? No?
Sir,
Oh, sorry. No, what my question is,
I think,
literature says that CT perfusion, I mean, we all know the CT triphasic, but from the radiology, what I want to know is what is CT perfusion scan and why we are not incorporating in our routine data to
I think
practice.
in want of time, we'll go ahead with the case.
if there is a multi-data CT, I think most
questions
of them
coming
will,
up.
where they're doing the.
Elegant, sir, you have a question coming up. Yeah. So antibiotics initiated by them, meropenem started on day 10. The repeat ultrasound abdomen showed a peripancreatic fluid collection which was ill-defined. Subsequently, they did an MRCP. It showed an ill-defined peripancreatic collection, increasing in size. Pain got better. He started developing nocturnal dry cough, early satiation, probably suggestive of something compressing the stomach and nighttime acid reflux. Again, he got somewhat better, discharged on day 15 from the onset of illness. So it was treated as an infection, but the cultures, nothing was proven. So yeah. Yeah. So there was a third hospitalization again with progressive cough and meager food intake. The nocturnal cough was persisting. On 20th day from the onset of illness, CT abdomen was done. Peripancreatic fluid collection of 10 centimeters in size, mild ascites, prominent CBD apart from the gallstone findings. LFT changes were very trivial and CBD was mildly prominent, 7 mm. Pain was persistent. Again, they did an MRCP and MRI on day 22nd. Reported as pseudosis this time with very minimal internal debris, less than 5 to 10%. It was referred to me at the end of third week. He came to me on 22nd day. So the next step, is an intervention warranted? If so, whether it can be a percutaneous or an endoscopic drainage. So specific questions for Dr. Ilangovan will be, what is the best imaging modality to evaluate a pancreatic fluid collection? What is the preferred modality of intervention? And what's the method of radiological drainage? In short, we're not asking about too much at length. And follow up after a percutaneous drainage, whether you want to upsize or downsize and when you want to remove it. Yes.
Good evening, everyone. Myself, Dr. Ilango. So, okay. So, I'm just, first of all, I would like to thank Mukundan sir and LVK sir for giving me this opportunity. So, first of all, this is a basics. I have just I just put basic few slides to for the PGs also. As everyone discussed already, the ideal imaging time is after 3 days, because even after only after 3 days we'll be able to pick up the collections and necrosis. Before 3 days, maybe we can pick up gallstones and other causes. The ideal imaging modality is CT. Even though MRI is coming up in a big way, the ideal imaging modality is always CT, and it's better to avoid oral contrast, because if you ask for a CECT abdomen, most of the radiologists will take with oral contrast, and you may miss some arterial lesions. The ideal is 4 phase, at least triple phase is needed. At least we should do 2 phases. One is pancreatic phase and venous phase. So pancreatic phase is the best one to pick up the collections. So necrosis greater than 30%, abscess formation have poor prognosis. MRI is useful if patient is having a kidney injury or iodine allergy, and it is useful for pancreatic duct disruption. particularly if there is a collection and necrosis, and we want to see there's a communication with the pancreatic duct or disruption, MRI and MRCP is useful. And radiology and ultrasound are not useful. Particularly most of the patients, within 3 or 4 days, when you are referring for ultrasound, we won't see the pancreas. That is the first sign of pancreatitis. And delayed imaging for complications. So as an IR, what we worry? We worry about pancreatic fluid collections, or we worry about arterial bleeding. These are the two things we worry about. So we all know the Atlanta classification. So the necrosis and the walled-off necrosis are the things we worry about. If there is a pseudocyst, extra pancreatic collection or a pseudocyst, the prognosis is usually good, and they are usually treatable also with a very good prognosis. So when do we drain it? If it's infected, if there is a suspicion of infection, or if it's symptomatic pseudocyst causing a mass effect, or patient is not able to eat because of the compression on stomach, then we go and drain. There is a big debate about endoscopic or percutaneous route. Both of these are complementary. Large bore percutaneous drainage permits future necrostomy. So we always prefer large bore percutaneous drainage. The maximum bore possible should be inserted. If the patient is sick, we usually do a 8 French or 10 French in the ultrasound, and then we upsize it to 16 French. And if it is a wall off or endoscopically accessible, US is best. And in timing, we usually do once it is walled off, because once it is walled off and we are able to access it, we do it. When to avoid? We avoid in asymptomatic, non-infected pseudocysts or spontaneous fistulas. And ideal is 3 to 4 weeks. Ultrasound guided, if the patient is superficial, if the lesion is superficial and patient is sick, we always prefer CT. And always we prefer retroperitoneal via the flags. And this avoids intestines and peritoneum. And future we can upsize it for necrosectomy. Sometimes we do in transperitoneal or transgastric, that is only for emergency cases, transhepatic. And Seldinger or Trocar technique. Trocar technique is just a direct puncture with a pigtail, but we always do Seldinger whenever possible. And only if the patient is emergency or ICU, then we use Trocar techniques. Otherwise, we always use Seldingers, and we try to upsize it to large bore. We do kissing catheters, 2 catheters, or double lumen catheter where we can aspirate and inject. And pigtail versus Malicot, I think we prefer pigtail. Many surgeons prefer Malicot. Nowadays pigtail catheters come with a locking mechanism, so we prefer that. So the thread with the locking mechanism, that is the one we prefer. And we always prefer the Seldinger's technique with wire. We puncture with the needle, take some samples, pass the wire, and we dilate, and then we put the pigtail. We always prefer the Seldinger's technique. Only if patient is very sick, we prefer the Trocar technique. Trocar technique is very simple, but the complications are more in Trocar technique. So mostly we prefer the flank access, but sometimes in sick patients we may have to come from transgastric or transhepatic also, but that's very rare. Mostly we prefer the flank approach. So people lavage with saline or local antibiotics or streptokinase. When to remove? Usually less than 20 ml fluid per day we usually remove. And patient is become clinically okay, then we remove it. So this is the basic. The complications, usually hemorrhage, peritoneal spillage, particularly if you are going from anterior approach, and that is why we always prefer the lateral approach. Anterior approach causes peritoneal spillage, and if there is a fistula more than 100 ml, if there is a drainage more than 100 ml for 3 weeks, mostly there is a high chance for fistula. So combined approach also, endoscopic lamps plus flank drain also is many studies have shown this to have superior results. Thank you.
So once the patient gets better, is your strategy is to downsize the catheter or tube size? Do you do that? You do that. At the time, do you encounter the leakage from the puncture site often?
That depends on the drainage side. If even after 3 weeks, if the drainage is more than the drainage is more than 100 ml per day, then we usually, if it's less than 20, we don't incur the leakages and all.
When will you upsize the drainage tube?
Usually in our center, we do a smallest one possible, like not smallest one, like 8-10 in the emergency setting, and then we upsize once the tract is mature. It is easier to upsize also. We put a 14 or 16 French drain.
So there's a paper by Pankaj Gupta from PGI actually. He used 2 protocols. And this was like not a randomized trial, but 2 protocols where one was rapid upsizing, per protocol rapid upsizing every 4th to 5th day. And the other one was standard of care. So what he showed was that the number of catheter usage was higher when they used the rapid protocol. However, the length of hospital stay was significantly shorter. So when you use the standard, you use a small catheter, you upsize only based on symptoms, then the length of hospital stays increases. But if you do a per protocol rapid upsizing, the thing is shorter, the hospital stay is shorter.
We generally start with when the patient is symptomatic, and I think the quantity of the quantum of necrotic material and the quality of necrotic material, if it is difficult to come, I think if you do an imaging, hardly any change, you are seeing getting only liquid, I think that's the time. Even without symptoms, you should upsize and try to get out.
So the next
One
question
more point,
for all the endoscopists here. If in case he has put a drain and it's not adequately draining, you do a repeat imaging and there is adequate amount of necrosum inside. So would you like to dilate the tract, go inside with your scope or ask the surgeons to do a ward, or would you be more comfortable going in for a LAMPS placement endoscopically? Which is your preferred approach, sir? Would you be sticking to one percutaneous approach and then asking the surgeons to do a ward, or endoscopy also do you bring in at this juncture after you have placed the percutaneous drain? If and when the drainage is inadequate.
So actually, the peripancreatic collection, the 3 things what we look at is whether it's retrogastric, paracolic, or diffuse. If it's retrogastric, something that's from the body or the tail, endoscopic support to add on to a step-up approach. Suppose if it is predominantly paracolic, then I think I'll ask my IR people to proceed and to upsize. Because another thing while upsizing, what the 3 points what they say is straight away 12 French minimum. Second, the catheter should be as straight as possible. Third, and the catheter is the most dependent part. And then if it is diffuse, then I think both should help.
So we can summarize that it depends on the location and whether all the collection has been drained or not. Okay, sir.
I think one message is very clear. IR failure is not an endoscopic indication.
No.
IR failure goes for surgical indication.
Yes.
So endoscopic failure, IR indication, yes. But IR failure is not an endoscopic indication.
This is exactly I wanted to say that when for a same collection with a good amount of necrosis, if you have done a percutaneous drainage, because that is indicated in the early phase when there is the wall is not mature and endoscopist is not coming in, or it is away from the prerogative for the endoscopist. In the same collection, I will never do an endoscopy procedure, even if the radiologist asks me, sir, can you do that? Because they have meddled with that. There is no stretching of the, because it may be moving away from that. And there may be a lot of vascularity there. So that is the place where you have to call the surgeons. Surgeons can do either percutaneously, they do all these things, or they can actually do a laparoscopic fantastic job on that.
So, yeah.
If it is away, if the percutaneous drainage is on the paracolic and there is a retrogastric one which requires drainage, of course I will take it up.
So, sir, what is your thoughts on percutaneous endoscopic necrosectomy in patients who are critically ill and not fit for surgery?
Yes, we can. It's actually done. And many times it is done by surgeons or by radiologists. Sometimes they even call us. We actually have put even esophageal stent inside, and we have used endoscope to go and take it out. And I'm sure surgeons also doing laparoscopy, similar equipments there also. They're also doing the same thing. So I think surgeons probably have got a slight edge because they can even go in laparoscopically also put in drain if it is not drained there.
So this case didn't go for percutaneous drainage because there was no paracolic collection or gutter. This went for a endoscopic drainage probably because the collection was predominantly in the lesser sac and very in close approximation with the stomach and compressing the stomach. So next presentation, before your presentation, so the specific questions for you, Matthew Phillips sir, is when to drain the collection and what are the risks of early drainage? We generally have a dictum of time-based, previous classifications have told either wait for 6 centimeters or 4 weeks. Does that still hold true? Or is there early drainage the incoming thing? If so, what are the risks of early drainage? If you are delaying the drainage, waiting for the older guidelines, what are the risks of a delayed drainage? What are the complications after the drainage you look for? And if there is a pseudoaneurysm, do you tackle the pseudoaneurysm before you drain it? And what is the nutrition after an endoscopic drainage? Would you like to put a nasojejunal tube and then feed the patient or an oral feed? Over to you, sir.
Thank you. Interesting case. And mostly I'll be talking verbally, but I will use some of the slides. See, you asked about a question, when will you drain? I think, the bottom line for any intervention is the symptom of the patient. Or a person worsening of condition or worsening of the severity of the pancreatitis in those situations, or patient is having. So basically I think it is a symptom. And just for information of our post-year students, we know that 2 types of pancreatitis, interstitial and necrotizing. And interstitial will lead on to peripancreatic fluid collection, and usually it is lead on to pseudocyst, while necrotizing can be peripancreatic or intrapancreatic, and it can lead on to necrotic collections, and that will ultimately lead on to walled-off necrosis. And pseudocyst occurs in those type of pancreatitis less than 20% or nearly only 5 to 10% in most of the series. But in necrotic pancreatitis, 50% of people can have this one. So in other words, you have got an acute pancreatitis fluid collection with acute pancreatitis as well as with chronic pancreatitis. And the bottom line or the major discriminating factor, different factor, is the presence of necrotic material. Post-year students, where are you sitting? What percentage of necrotic material you decide for drainage modality difference? 30%, very good. I think there is no need of any class for these people. So I think, intervention is decided on symptomatic. It can be an organ compression, or patient is not improving, or the patient has got evidence of infection. That means, you have got radiological evidence or clinical evidence or biochemical evidence. The patient has high procal, Sudipta may not agree, procal with CRP with high counts and all those things in a particular period of pancreatitis. That means after 2nd week of this, or the patient is having persistent pain. In the patient is, even if the patient is not in the right time for drainage, patient is having severe pain, patient is having severe disease progression, and patient is not improving because of a compartment syndrome. In those situations, I think there is an indication, even if it is an early situation, you have to do a drainage. So compartment syndrome is actually one condition where you put a drainage early, but it is not endoscopically. Drainage means it is not only the, even though I am treating the patient, I am not the person doing everything. It's actually done by radiologist, done by surgeon as well. And regarding nutrition, you asked, I think this is a very important part. And I start nutrition very early. Why? Because many times they becomes bad and I may not be able to take them out for a nasojejunal tube. And mostly if the patient has severe acute pancreatitis, I prefer to put a tube feeding, and because that really helps them in improvement of that. But I agree that literature doesn't support that. It says that nasogastric tube or oral feeding, if the patient is able to swallow, everything is fine. But if the patient feels hungry, that means he is improving, and then you can actually start oral feeding in those patients. And as I told you, this drainage can be percutaneous, endoscopic, or surgical. Just because the patient is in a gastro ICU, that does not mean that we should drain everything through endoscopy. This is the evolution. I personally think, as well as literature say, a step-up approach is much superior. But recently there is a study which says that probably you intervene early and go in and get in the necrotic material early enough. But I think it is basically nutrition, general management, and then finally you do a drainage depending upon the situation, time, as well as the place of the collection that decides the approach of that. A paracolic cutter, it is always percutaneous, even if it is delayed. And if it is an early drainage from lesser sac, I think it is percutaneous drainage, because if the wall is not mature, your other question is, what happens if you drainage very early? If your wall is immature, it is an ill-defined one, and it has not made any reasonable addition to the wall of the intestine or the stomach, then it's unlikely that you are going to make a effective drainage. And it happened to me. I enthusiastically drained it in the past when there was no US guidance, and I put the drain. It was a plastic drain. The patient improved immediately. The whole thing disappeared, but he developed peritonitis. The patient was taken up to theater, and I found that the stent was hanging from the stomach down. The whole cyst has disappeared. It was actually an ill-formed wall, and it's a large cyst. Patient was symptomatic. What will happen if you are not draining? A patient came to me with a huge abdomen, and patient was a little sick, so we told that we optimize him with nutrition and wait for that. And in the middle of the night, I got a call that he had a massive hematemesis. This man vomited out after a rupture into the intestine, the whole thing out. And he actually collapsed. Finally, we had to take him for surgery. So this can occur. And delaying late, sometimes, you can develop pseudoaneurysm. The question of pseudoaneurysm, how do you tackle? I always send the patient for interventional radiologist. And once it is embolized and obliterated, then only I will do the drainage. I think that is the thing which you wanted to ask me. Is that sufficient? I will just show you some, this I think he will say. I think these trials are quite important. I'm sure you must be knowing about all these trials. Panda trial, Penguin trial, Tension trial, Miser trial, and evolution of endoscopic drainage, which we are talking now. And what are the issues in endoscopic drainage? We want to know whether it is percutaneous drainage versus surgical drainage or endoscopic drainage. Is endoscopic drainage superior in all the aspects? Not necessarily true. Plastic stents versus metal stents. When to do a necrosectomy, and when to remove the stent, and when to take up another modality of drainage, how to manage the disconnected, which I'm not going to detail. In pseudocyst, it is very simple. If the patient is symptomatic, mostly these symptoms are pressure symptoms, or very rarely it's infected pseudocyst. In those situations, it is a drainage, and if it is infected, you have to do a nasocystic drainage, otherwise you do plastic stent or more. And coming to walled-off drainage, I think it is very clear. If there is a justification for doing that, if the patient got a symptom, and mostly I do after a CT scan, if the wall is reasonably mature, it is actually close to the bowel where I can do a drainage, and I will do an ultrasound, because CT scan may not show the necrotic material. I will do an ultrasound and make sure that there is adequate walled-off necrosis, of presence of debris. Then I will plan what type of stent I need to use. Of course, when we do an EUS, that will tell us whether there is adequate, there is significant necrotic material or not. Multigate, you should know, some examiners may ask you what is the multigate technique, putting multiple stents in that. And in patients with walled-off necrosis, when there is more than 30% of necrotic material or debris, you need to put a lumen opposing stent. These are two situations, one from the stomach, one from the duodenum. It's an easy technique, one step process. Actually a single approach, you can put the stent and drain it very well. One is Nagy stent, another is actually lumen opposing stent or access stent. Metal or plastic, truly speaking, there is not much difference as per the literature. But if you ask me, if there is a lot of debris, I would prefer a self-expanding metal stents. And we just put the stent and then come off. We will wait. If the patient develops symptoms, we do the declogging first. Still symptomatic, we'll put a drainage tube. Or we then go for endoscopic necrosectomy. Direct endoscopic necrosectomy in the first session is uncommon in my department. When to remove the stent and complications of stent. Generally, plastic stent we retain for long, and sometimes I even retain it for lifelong. Because if there is a connection, a disconnected pancreatic syndrome, many times I retain the stent. And now recently some studies have come out that even if you take out the stent, nothing may not happen in majority of the patients. But that is my policy which I have been practicing for long. And metallic stents, usually after 2 weeks, up to before 4 weeks, we take it out. Suppose you don't take out the tube, delayed, what happened? It can get embedded, then there can be bleeding as well, especially Lamb's tube. So the algorithm is like this. When there is a symptomatic pancreatic fluid collection, you do EUS bar MRI basically to find out the amount of debris material there. If endoscopic drainage is feasible, that means it is close to the stomach or duodenum, or if it has got necessity for doing through endoscopy, then we'll go for that. If that is not, you send the patient either for a percutaneous one or to the surgeon. And if it is yes, if it is pseudocyst, we just do a EUS-gated drainage, and that we'll do a plastic stent. And then if it is walled-off necrosis, then they will actually use either multiple plastic stent or lamps. Thank you.
So the last question was post-drainage, your preferred modality of feeding a patient. Do you prefer to start them on oral diet or nasoenteral feeding?
See, post-procedure, if the patient is clinically much better, I always give oral feeding only. Because the patient is relieved. Patient is feeling hungry, is able to eat. Food is not going to go into the... But generally I don't give them PPI. Because the acid will go and necrose, that will digest the debris there. So it's better to avoid PPI in those patients.
Is it practical to avoid PPI all the time, sir? Because most often
I do for the first 2 days of the procedure I give, because I have punctured there is a wound there, so probably I'm scared, because I'm scared I do. Otherwise I don't give. Because it's better to not to give PPI in these patients.
So there is a paper by Moin Kashab on the same topic, and actually he has shown that if you do not give PPI, the rates of resolution, it's a very small case series of around 10 or 15 patients, but he's shown that it improves faster.
During endoscopic ultrasound, if you pick up some vessels around the pseudocyst, do you embolize it empirically and then you take up?
No, see, we can, the beauty of EUS is that actually you get a wider area. If it's a very narrow area, of course it becomes difficult. We have done many times in patients with portal vein thrombosis, multiple collaterals, but still you find out a way. And mostly, it just never happened to me that patient has cirrhosis, patient has got EHPVO, and we had to stop drainage. But the patient has got severe coagulation failure, patient got severe thrombocytopenia due to cirrhosis of liver. That may be a relative contraindication.
Even if the vessels are there, we put a lamps, it kind of gives a tamponade. Most often we call you when the lamps kind of erodes the vessel or it forms a pseudoaneurysm in that particular region. After 2 weeks or so, we have such a scenario. That's when we call in the radar. And at the time, you will have easy to put a coil there because you will have the stent as a guide, the lamps as a guide. Yeah.
So I have one question, sir. So by many a time when we put in drain, percutaneous drain, then the patient is not improving, we upsize the drain and all that. But when we have adopted a protocol to put in an NJ forcibly, convince the patient and do it. Many a time we see many of these collections disappear, the SIRS also comes down. Of course, pancreatic rest, all the feedback mechanism, but we seem to get the patient out of all the sepsis and everything. If the anesthetist is willing to support the patient during the NJ insertion, we find that they improve very well after that.
I agree that nutrition is a very important factor in this one, and actually maintaining or engaging the intestine with the food actually improves or reduces the chance for infection. This is because the translocation or bacterial translocation may come down because the intestinal mucosal edema comes down, all these things. But I think, in those patients whom we are talking about, percutaneous drain is a different entity because, you start it early. And the patient is actually draining a lot of protein, everything is going out. So in those patients, you have to give a lot of nutrition. If the oral intake is not sufficient enough, I think, putting an NJ tube to enhance his nutrition is very, very really appreciable. Usually, I, on the little delayed side, after third week only, I generally do that because I have noted that there are many people doing beyond that. It's all confidence, experience, etc. But generally, I have felt that the radiologist will tell us that the wall is not mature. You do an EUS. It is a very thick area. It is a very shaggy area, and it's a very irregular area. And you feel that there is no inflammatory changes over the stomach in that particular area. Why I am telling is inflammatory changes, that means it is getting adherent to that. So it is not going to get away from that. So when you puncture, if there is actually no inflammatory changes or the pseudo gastropathy sign or snake skin appearance which occurs when there is a compressive inflammation that occurs in that particular area, that shows that probably it is at least partially adherent there. Then you are safe to do that. Otherwise what happens is, you see a bulge there, you puncture it, the bulge will disappear and the stent will be hanging on the stomach. You do an operation, laparoscopy, GV Rao will take a photograph and show it in the next conference. Matthew Philip has done like this. Okay. So I think, a little on the delayed side, but don't delay too much because you can get other complications, infections, secondary infections, and bleeding, pseudoaneurysm developing, because this will erode the surrounding vessels and produce bleeding on that. So that is what happens. But usually it's around, ideal time to me is 4 weeks, but sometimes I do a little earlier also.
The reason why we come up with the early drainage is twice I have also experienced this, waiting for this 4-week magical number. 2 cases, the collection ruptured into colon. So one I got away with, one went into a very bad sepsis. Once it ruptures into colon, you have to call in the surgeon as early as possible to prevent a catastrophe. So moving on to the last part. So though it was amenable for endoscopic drainage in this case, it was a gallstone disease and it's almost approaching the 4th week and patient was symptomatic. He was not able to eat anything. So I called in my surgeon. I said you go ahead, let's try and do a laparoscopy. You go ahead and finish off the gallstone management, lap chole, and you find out if there is a cyst wall is mature enough for you to do cystogastro or you want me to do endoscopy. We always do tandem, so that's one good thing. So we go hand in hand. So he did the lap chole, he found out that there was some pus in the hepatorenal pouch, and he said, your EUS has a good vision, why don't you go and drain it? So I went in and there was very little debris, so we put in a plastic stent, 2 plastic stents, 10 French and 8.5 French. The drainage was good, we collected the pus and everything. Patient was doing, in fact, extremely well for the next 2 days. On 3rd day, he developed a fever. So there was no pain though. On 4th post-op day, there was an indication for endoscopy because there was a 2-gram drop in HB and there was melena. So I had 2 indications to do an endoscopy. One is to do a dilating of the cavity and one is to assess why the melena was there. So to my surprise, when I went in, the stent which I placed, which was projecting into the esophagus and the pigtail was compressing on the esophagus, it formed a very deep excavated ulcer. It was the first time I'm seeing it, so that was actually bleeding out. So we dislodged that stent and kept it in the stomach. Other than that, I entered the cavity, gave a thorough wash. I told the patient, you know what, you'll be fine, happy. And evening he developed pain and next day his fever worsened, counts went up, CRP shot up. In spite of me doing a thorough wash, what I thought was a thorough wash, did a screening CT, there was worsening of the left side pleural effusion, there was some new perihepatic area collection, but the lesser sac collection was almost gone now. So there is some few air shadows in the lesser sac and stomach, the stents were patent. But now the collection here and there worsened, so there was a single time aspiration from the pleural effusions and right hepatic area effusion. We upsized the antibiotic to tigecycline. He got better in 2 to 3 days time. So he's now discharged 9th POD from the lap chole and endoscopic cystogastroscopy. Now he's doing fine. So the questions to GV Rao sir. What is the timing of cholecystectomy for you? And will there be an aggressive approach from your side or a wait and watch approach as a surgeon? And endoscopy versus surgery for necrosectomy. What is your approval rate for endoscopic necrosectomy? And if there is a cyst in the tail, is there a distal pancreatectomy or a cystojejunostomy in your approach? And whether you're worried about this patient developing diabetes, so do you want to still preserve the tail of the pancreas or go for a cystojejunostomy, which is easier in your case? Do you want to slap the endoscopist now or shake hands with him, saying that this approach is also good enough? Over to you, sir.
Slapping the back. Tapping the back.
Audio, sir, no? If possible. At the outset, let me thank the entire organizing committee for including me in this meeting. Actually, I think I'm the only odd person out in this, actually. I think other than Ratnaswamy who's sitting here. If you've seen the entire discussion of peripancreatic fluid collection seems to be centered around endoscopists and radiologists. Except for Matthew Philip, who mentioned about surgeons, all other speakers were just talking about endoscopy and radiology. This is basically because the last 2 decades, I think we are getting more publications. Initially, it was interventional radiology who were in the forefront. Endoscopists became more aggressive, and there are innumerable publications coming from endoscopy side. So this led to the assumption that surgeon can be in the background, and we don't have any big role for surgeon in current day clinical practice. This is a cartoon which came in actually when I did the first notes procedure. Again, it is resurfacing again with the peripancreatic fluid collections and the other endoscopic procedures that are happening right now. Now, the primary and the secondary endpoints of both the radiologists and endoscopists is to avoid surgeon and avoid surgery. This seems to be the primary endpoint. I mean, with due apologies again. But if you look at what happens is, if you look at fundamentals of pancreatitis management, we have surgeon in every part of management of pancreatitis. And surgeon does not essentially mean surgery. Gastroenterologist doesn't mean endoscopy. Surgeon is part and parcel of the entire management team, and there is level 1 evidence to show that surgeon is a part and parcel of the entire management team which deals with patients with acute pancreatitis, and we have to take decisions depending on the course in which the patient goes during the entire management. Now, over the last 2 decades, the outcomes are basically because of evolving techniques, be it endoscopy, radiology, surgery, and encouraging results, better understanding of the disease. Actually, we have very good publications coming from Vellore, PGI Chandigarh, AIMS actually to show this. We have better imaging modalities. We have better intensive care and ERAS protocols that are responsible for the outcomes. All of us keep thumping our chest saying that the radiology, endoscopy is responsible for the outcomes. No, it is the interventional radiologists who are responsible for a significant portion for the better outcomes that we see in these patients. In every part of acute pancreatitis, early, late, mild, moderate, severe, edematous, interstitial. The question that is again asked is, do surgeons have a role in first 4 weeks? Now, these 2 papers have created this big discussion. One from the radiology side, one from the endoscopy side, wherein they try to intervene before 4 weeks to see if there's any indication. Some indications, but again, the amount of morbidity, mortality is significant in these patients. Etiology of pancreatitis, I mean, we don't have to go into this. There is level 1 evidence to show that whenever a patient has got mild acute biliary pancreatitis, cholecystectomy should be done in index hospitalization. And whenever this is done in index hospitalization, if you adhere to this, there is decrease in subsequent hospitalizations and also the decrease in subsequent biliary complications that can occur. So for mild biliary pancreatitis, index cholecystectomy during index hospitalization is the indication for this. And even actually, because most of the endoscopists and radiologists don't seem to believe in this, so they got the AI component into this right now. This is a beautiful paper which incorporated AI, and even AI tells you that For mild biliary pancreatitis, cholecystectomy should be done in the index hospitalization. Now, this surgery for early, less than 4 weeks, was tried by surgeons way back in 1997. This was the first ever randomized trial that came in. And they stopped this trial basically because of the increased morbidity that was shown during this period. And subsequently, we all know that we have to wait for quite some time before we can intervene in this patient. Though we had some data from surgical side saying that this is a very small series that's saying that you can intervene early and we get away with these patients. Some indications for abdominal compartment syndrome, but we hardly ever intervene for any abdominal compartment syndrome in current day clinical practice because of better managed by the intensivists as and today. Now, radiologists, again with due apologies, please. It is not PCD, it is PCDs. It could be 1, 2, 3, 4, 5, 6, or 10 also. I mean, this is what is radiology. Though there is a lot of radiology that is coming in, to show that early thing can be done. But if you see this, actually any of these endoscopy or radiology procedures, there is a significant amount of these patients who are going for surgery in this patient. 15% or 20% is not a small number in this. And if you see any of these series that you see, if you have an early PCD or an early endoscopic drainage, any of these series that you see. So if you ask me, do surgeons have a role in early, in the first 4 weeks? I'll strictly say there is increasing role basically because both the endoscopists and the radiologists seem to be intervening early. And the complications of this become the indications for surgery. So the timing of, actually, I don't know when, I think Sudipta should tell us actually how many cases you really go in early in current day clinical practice. We always would like to, it's a very small percentage of patients who go for intervention less than 4 weeks. And early interventions actually for surgery, basically it causes increasing bugs, increasing ICU stay, hospital resources, finances, surgery. And if you ask me for first 4 weeks, do you have any role? Cholecystectomy, yes. Some complications which I'll tell you, and it is the complications for either the endoscopists or the radiology interventions. And the only indications would be as a continuum in the step-up approach after percutaneous or endoscopy route, acute ongoing bleeding, any bowel ischemia that you suspect, necrotizing cholecystitis or a bowel fistula that you have. These are the only indications that we talk about during first 4 weeks. And after 4 weeks, again, there is a lot of debate about these procedures, but I think the type of intervention should depend on quantification, qualification of the debris necrosum, site and extension of the wall of necrosis, avoiding selection bias in published series, please, and can be done is not should be done. Basically, functional status of the patient should be taken into account, expertise in the financial status. Again, a repeated thing that is often quoted is patient unfit for surgery is taken up for endoscopic intervention. I think better change your anesthetist, please. As in today, majority of the endoscopic procedures are done under anesthesia only. How can unfit patient become an indication for endoscopic indication? So this actually, this unfit for surgery is not an indication for endoscopic intervention. Please, actually, I think all of you will agree to this. And it is multiple sessions of anesthesia as compared to single session of anesthesia for surgery. Basically, I think it has to be actually, even we had this problem in our own department actually. We have a very strong radiology department, very strong endoscopy department, and not very strong surgical department, but we raise our voice occasionally to say that even we can do some procedures. See, actually, if you ask any of the endocrinologists here, please, can you tell me one procedure that is accepted for all the things actually? Everybody actually have shown different procedures, right from putting in a plastic, metal stent, multiple gateway, I mean, whatever, there's no consensus as on today as to what is the standard of procedure for this procedure as on today. It is all depends on what is practiced actually. Till 2021, it is actually, the endocrinologists talked about the drains which are in close approximation to the stomach and duodenum. And because now you're not able to do majority of the thing, now after 2021, all the trials, I'll show it to you with evidence, are endotherapy combined with interventional radiology. There is nothing, only endoscopic ultrasound is. So you have to know that you have some limitations of both endoscopists and interventional radiologists also. And as in today, it is mostly for complex, whichever drain, wands which are extending beyond the stomach. I think it is basically a combination of different modalities. And this is the only thing that came in actually from Delhi, AIMS group, which showed that endoscopy is as good as laparoscopy, or I'll put it as laparoscopy is as good as endoscopy whenever we have debris less than 30%. And we have a lot of data to show that, laparoscopic procedures, if done de novo, can be done very effectively. If you're coming to surgery per se, though in majority of the postgraduate may not have seen this because most of you on the medical side actually, we have any of these procedures, again, if we have a good anesthetist, any of these procedures can be done in a single stage procedure laparoscopically, irrespective of the site, extension, amount of debris. And majority of the time, it is a single stage procedure. This discussion about cutaneous fistulas that happen, the pancreatico-cutaneous fistulas that happen only with collections which are beyond the stomach. If I do a laparoscopic cystogastrostomy, where is the appearance of a fistula subsequently? Don't try to compare these things with everything and say that the incidence of pancreatic fistulas is more in surgery. So everything can be done, provided you have a good surgeon with you who can do the procedure, like you have a good endoscopist with you, or a good interventional radiologist we have. And we have a lot of data to show that the laparoscopic procedures can be done with safe, and our own data from our own country shows that primary laparoscopy can be done. Again, there is a lot of difference between ward and transgastric procedures, please. Ward is a thing that is coming onto the retroperitoneal side. It cannot be done for a procedure that is going through the stomach. Predominantly, ward is for wall of necrosis which are pointing onto the flank, any of those things. Therein we can go in and drain this thing. But it is not for procedures which we have to go transgastric. So these procedures can be done because the instruments are rigid. We have wide bore trocars, rigid instruments, and it can be very easily debrided in single setting. And even as in today, there's a lot of debates asking about open necrosectomy. Endoscopic failure, we cannot do laparoscopy, please. See, somebody has to feel the thing. The bulge is an indication to show where the necrosum is. Once the cavity is decompressed, there is no way that you can feel it laparoscopically. Endoscopic failure or a laparoscopic failure straight goes for open surgery. There is no way that you can tackle these patients laparoscopically. So current day, all the endoscopic failures or laparoscopic, I don't call them failures. If they're not responding to it, actually these have to be considered for surgery. The only thing that is practiced right now is the close continuous lavage as in today, wherein the entire necrosum is removed and then you put 2 drains and then irrigate these patients, and then they do very well. And is it the last resort? Maybe the last resort, and in some centers actually even it is practiced as the first resort wherever they don't have access to the endoscopy procedures. Again, we do apologies again. You keep saying that I keep showing photographs. You also keep showing photographs of post-cholecystectomy biliary leaks, putting in stents and showing us that these are the complications produced by surgeons. So these are the things that we see day in and day out actually. Stents in the peritoneal cavity for fluid, stents put in for this, stents that migrate into peritoneal cavity. These are not unusual, please, because these are the things that are usually seen but not reported anywhere. And these are the bleeds that occur actually, erodes into the massive retroperitoneal veins actually. These cannot be salvaged by any of the endoscopic procedures or even by interventional radiology procedures. Especially the stent actually that we see, the lumen opposing stent actually, but the Nagy stent actually is slightly roughened actually, that can cause this sort of erosions. And whenever we have any fistula communicating to the bowel, and which is continuously in communication to the wall of necrosis, I don't think no form of endoscopic drainage or interventional radiology will help. These patients obviously require surgical intervention. And whether you like it or not, stents do migrate into. This is one of the lumen opposing stents that was put for a walled-off necrosis, migrated into the peritoneal cavity. Don't ask me how, but this is how it happens. It happens actually. So again, again it was said that this patient was unfit for surgery. An unfit patient for surgery becomes an indication for a laparoscopic drainage after an endoscopic failure. So please, unfit for surgery is not an indication in current day clinical practice, especially for advanced endoscopy procedures, because they are done under anesthesia only. And outcomes of these procedures are not as bad as the gastroenterologist or the interventional radiologist project. The mortality morbidity is not very high, it is very low. And if you see the index thing, the mortality is very low as compared to what it was before. And even in our, one of the premier institutes, actually, Gangaram Hospital, actually, if you see, one of the commonest procedures that is still done is an open necrosectomy in current day clinical practice. It is not that it is not done. And this is a beautiful paper that I keep quoting actually. This has got endoscopists, interventional radiologists, and surgeons of repute who have participated in endoscopic data, interventional radiology data, and surgical data. And if you see this, still surgery has got a role. Just because it is shown that actually endoscopy and radiology is the procedures, it is not that, you should not get carried away by the message that surgery has got no role in this. Primary centers is still the practice. So if you ask me, actually in my center, actually as I told you, we have good interventional radiologists, very strong endoscopists, and mediocre surgeons like me in my department, but still we get patients for necrosectomy. And if you see this, patients who come for primary surgery, the mortality is very less. But if they come after PCD or an endoscopic ultrasound intervention, the mortality is high. So if you decide on these patients, which patients have to go for which treatment, I think ultimately the patient will benefit. This is the algorithm that I think I strongly put it actually. If it is an approximation to the stomach and duodenum, less than 30% debris, endoscopy, no doubt about it. And if endoscopy is not available, you do surgery. More than 30% debris depends on whether you have expertise or not, open or laparoscopy. And if it is beyond stomach or duodenum, I think we have to weigh the pros and cons of individual procedures, your expertise, and the general condition of the patient, and take a condition on this. And beautiful paper which shows that actually it is something like, we have a wall of correction which is absolutely in approximation to the stomach and duodenum. Endoscopy is the best. And if you have a good endoscopist, debris is not the concern, you do the necrosectomy also. But as the walled off necrosis is going away from the stomach, it's going away from the stomach and the duodenum, the indications for radiology and surgery become more and more. This is very true that one size does not fit in. You have to take a multidisciplinary approach and discuss with everybody. In Tamil Nadu, I cannot get away showing this. If you ask me, is there any role for surgeon? Yes. Rajinikanth is the boss. Whether you like it or not, Rajinikanth is the boss surgeon today. Whether you like it or not, yes, surgeon has got a role. You have to consider this thing actually, because we see a lot of these patients actually, at the end, we got the low albumin, and that's the time that you ask a surgical consultation, and you tell us that the surgical results are very poor. Please, I think an appropriate time, the patient comes, because the postgraduates here, I think the message has to be very, very clear. Good tumor board, a good pancreas board, to decide which patient has to go for which intervention, rather than trying to say that all patients have to go for interventional radiology or all patients have to go for endoscopic drainage. Thank you so much once again.
Sir, can I ask a quick question?
Please.
We all know that in mild acute pancreatitis, cholecystectomy at admission is a very clear indication. What about patients with severe acute pancreatitis like this patient who has got multiple collections? How do you time the cholecystectomy?
Yes, actually, see, once the patient has got multiple collections, if the patient is going for a laparoscopic intervention, cholecystectomy can be done at the same time. But if the patient is going for an endoscopic or a radiology intervention, I think the cholecystectomy can wait.
So do you wait for the inflammation to subside to decide on cholecystectomy, or that's intra-abdominal? If it's a very hot abdomen, are you happy to do a cholecystectomy?
It's a very good question. What happens is majority of the time the inflammation spreads among the hepatoduodenal ligament. Actually, there is a lot of inflammation in the hepatoduodenal ligament, and the incidence of bile leaks is quite high when we do these procedures. And especially whenever we do this, actually we stop putting those metallic clips for this for the cystic duct. Now we have those Liga clips which we use actually, but in spite of that, sometimes this thing literally cut through the thing, and the incidence of bile leaks is slightly very high. So I would rather wait for some time till the whole thing settles down and then do cholecystectomy in this patient. I'm sorry about this presentation because I heard this presentation. I thought some messages have to be clear because there is some role for surgery, please.
GV, a very good presentation. See, in my unit also, still we give patients to surgeons. And a patient who requires cholecystectomy and patient has got a Waldorf necrosis, which sometimes I ask the surgeon to do it combinedly. So this is quite common. Even recently, we used to have patients for open necrosectomy. When I think that the patient is not suitable for endoscopy, I refer. No, so actually, surgeon is an integral part. We are not here. You are with us. Actually, the pictures I told because we take very good photographs. That is why I told. I had made communication, but I never got a good photograph of these things.
So
it's actually good.
We have come to the end of the session. So just to wrap up, for the PG's sake, it is not a competition between a surgeon or an endoscopist or a IR. It is a multidisciplinary approach. That's the message which we are trying to send out. That's what sir is also, GV Rao sir is also trying to say. He may appear as though he wanted to slap, but it's actually a handshake. He's a very friendly person. So what we are trying to summarize is, first week nowadays, manage the acute pancreatitis very well so that it doesn't mishap into a fluid collection or an infected necrosis later. In spite of your best efforts, 5% of the cases will end up on the 4th week with some infected collection. Manage it very well with a multidisciplinary approach. 4 weeks for the PG's sake, but the gray zone still exists. It's either the early onset of 3rd week or sometimes it can be 6 weeks. Manage at the appropriate time, discuss with the surgeon and radiologist. That's how we are supposed to manage. And regarding Madra's take on nutrition, it's according to the Dutch Pancreatitis Group Studies trial. Earlier the enteral nutrition, the better it is. But depending on the case-by-case scenario, if the patient is not tolerating, go for nasoenteral feeding. Regarding removal of the metal stent, remove it after doing an MRCP at the end of 3rd month. If the pancreatic duct is not disrupted, remove it off. That is a plastic stent. Remove the metal stent at the end of 4th to 6th week, because beyond which there are complications. If you put a plastic stent, you can remove at the end of 3 months. If the MRCP shows up, patent duct. If it doesn't show, leave the stent lifelong, nothing will happen. Once in a while, if it gets infected, go and intervene. So that is the summary which we want to tell. Metal versus plastic. We do say that less than 30% necrosum put a plastic stent, but invariably if you put a plastic stent, you are actually infiltrating a sterile pancreatic collection. It is going to get infected. Be prepared to tackle the infections. So most often people prefer a metal lamps over a plastic to just avoid an infection. So it depends upon the financial status also. So a pancreatic case comes to you at the end of 4th week, it's probably going to stay with you. So the message sent out by Matthew sir is also, stay with the patient on the 1st week very well, treat the SIRS very well so that it doesn't come as scars to you later. Thank you for the panel, and thank the organizer for the excellent opportunity. Thank you.
Thank you, speakers and moderator, for the excellent session. Now we will break for tea. We'll come back in 10 minutes. That is, the next session will start at 6:05 p.m.